I'm Dr. Mike Lenore, and this is the Wellness Watch.
Welcome to the African American Wellness Watch. I'm your moderator, George Strait. Heart disease. It's still the #1 killer in America despite the remarkable advances in prevention and treatment. So why is that? And why do so many African Americans continue to suffer with it? We're 30% more likely to die from heart disease than whites, 30% more likely to have high blood pressure than whites, and 40% more likely to have high cholesterol. So what do we do to fight these trends? Well, our guests today are among the world's leading experts. Dr. Alden McDonald, an interventional cardiologist at Stanford University. Dr. Quintus Enix, a world-renowned heart surgeon and expert in patterns of disease and patterns of care. And our host, Dr. Michael Lenore. Mike, why don't you get us started?
Well, I want to welcome everybody to the Wellness Watch again, and it's just my privilege to introduce two very, very famous and competent doctors, well known not only in the East Bay and other parts of the country. Dr. McDonald is a cardiologist, great distinction, and Dr. Enix was a cardiac surgeon in the Bay Area, still is a cardiac surgeon in the Bay Area, and under even the most difficult circumstances as an African-American surgeon, has established one of the finest reputations in the country for the procedures that he is able to do. So today I'm really excited to hear some more contemporary information about about heart disease. And I'd like to start with you, Dr. McDonald. Why do Black people have so much more difficulty with heart disease than other ethnic groups?
Well, thanks very much, Dr. Lenore, for that question. And I just want to first say I'm honored to be part of this discussion. I want to thank the African American Wellness Project for all the work that you do to amplify these conversations. And it's an honor to be here with Dr. Enix as well. As was alluded to, I mean, heart disease is still the #1 cause of death for Americans. It's even worse when you look at it in the African American community. So when we look at even, let's take all-cause disparities in mortality or in life expectancy. The disparities that we see between white and Black Americans in terms of life expectancy is a large part of that is explained by disparities in heart disease. Probably at least a third of the disparities in life expectancy are explained by disparities in heart disease. And so why is that? I think it's important to just understand a little bit about the basics of heart disease that can inform our conversation moving forward, because we can then understand what some of the issues are in terms of prevention and treatment. So when we're talking about cardiovascular disease, there's multiple types. There's coronary artery disease, there are valvular heart disease, there are arrhythmias and abnormalities in the heart rhythm. But the predominant cause of death due to cardiovascular disease, probably a little over half or so, is due to coronary artery disease. So that's a lot of our focus. And coronary artery disease refers to blockages in the heart arteries. So just to give a little bit of the basics, the heart's job is to pump blood to the rest of the body. All the organs need blood flow and need oxygen. Your legs need oxygen and blood flow. Your kidneys need oxygen and blood flow. Your brain, same thing. Your heart is no different. So your heart requires blood flow to the heart itself, to the heart muscle itself, to do its job. And so there are arteries that supply the heart itself with blood called coronary arteries. And coronary artery disease refers to blockages in those arteries. So imagine arteries are like pipes that carry blood to the heart, and those pipes can sort of get clogged up, and they get clogged up by something called plaque. Plaque can be a collection of inflammatory cells, fatty deposits in the wall of the artery, in the wall of that pipe that start to close the pipe. And when blood flow to the heart is impaired, then that causes a problem for the heart function. A heart attack is when the vessel becomes acutely blocked. So I sort of explain it to patients like this. A plaque is sort of like a pimple in the vessel. like a pimple is on the skin. It's raised, it can be inflamed, and it can grow. And a heart attack occurs when a plaque ruptures or when that pimple pops or bursts. When the pimple pops, what happens? You bleed a little bit and a clot forms there, or a scab, because you don't bleed to death from something on your skin. The same thing happens in the small artery. Plaque ruptures, clot forms, and that blood clot then blocks the artery. That's an acute heart attack. So the real question is, how do we prevent an acute heart attack? How do we prevent the plaque from building up in the first place? And so that's what we often refer to as cardiovascular risk factors, factors that lead to the buildup of plaque in arteries. And those factors include high blood pressure, high cholesterol, diabetes, smoking, obesity, lack of physical activity or inadequate physical activity. And African Americans have higher rates of all of those risk factors. In particular, hypertension. The prevalence of hypertension in the African American community is really astounding. Prevalence of over 40% for African Americans over the age of 20, and well over 50% for those over the age of 50. This is much higher than in other populations. So the diabetes, same thing, higher prevalence, obesity, higher prevalence. So when African Americans have higher prevalence of these risk factors, they're more prone to having plaque buildup in the arteries and being more prone to heart disease, and in particular, heart attacks.
So if I might get Dr. Anderson in on this. So why is that? Why is the prevalence so high? I know it's not a simple answer. It's very nuanced, but if you get into some of the reasons why you think the incidence remain high, folks have known about eating right and exercising and all the rest for years. And there are lots of treatments and new drugs and all the rest. But yet the incidence is still so high. Give us some reasons why.
Thank you very much. First, let me thank you for having invited me to participate in this panel today. I know that George Strait and Michael Lenore have been in the vanguard of equity and healthcare for decades, while Dr. McDonald is a young physician and newcomer. He is certainly and has continued to make his mark in this arena. In terms of your question as to why there's a difference in outcomes and results, there are in the main three primary reasons, I believe: access, socioeconomic factors, and the history in our country of racism. All of these areas have been approached and have been studied extensively. And in some areas, things are getting better. But as you know, the Supreme Court of the United States offered an opinion today that's going to end consideration, or has ended consideration, of race in admissions. And so that's going to put a damper on the number of physicians that graduate from our institutions. And that will have, I believe, a detrimental effect on outcomes as well. But specifically to answer your question, George, I would say access, difference in socioeconomic status, and a history of racism in our country.
As far as that, what about the incidence, especially among young children? I've heard that obesity is getting younger and younger, and diabetes kids are getting younger and younger. In your practice, Dr. Lenore, which is primarily one with children, have you seen an increase not just in heart disease, but also in some of the primary risk factors for heart disease? There are more and more kids in your practice at risk for serious heart disease if they don't change their lifestyle, if you will.
I do appreciate Dr. McDonald and Dr. Enix explaining some of the risk factors, but in my practice, what we're looking for is an opportunity to intervene with young children in the lifestyle that will lead them to a healthier cardiac situation. But what I'm seeing is an increase in one particular factor, which I think is very critical, and that is obesity. I don't think I've ever seen, or maybe I have, but maybe I don't remember, as many children who are grossly obese and also who are ghastly overweight. And that's both boys and girls, adolescents especially. And so consequently, what we're trying to do is we're trying to screen them, excuse me, look for their lipids, and look for their weight, try to get them in programs that help them reduce at this particular stage. Because by the time they get to be teenagers, they're already on the road to Dr. McDonald's office and into Dr. Cornacini's very capable hands.
And Dr. McDonald, let's talk about some solutions, if you will, or at least some interventions. As I said earlier, there are lots of new drugs out there to combat coronary artery disease. There are lots of new interventions, and I know that's what you do. You're an interventional cardiologist. So talk a little bit about some of the new treatments, new medicines, and the new interventions.
Sure, and let me just build up first on what Dr. Lenore said. You know, we have seen strides in decreasing cardiovascular mortality over, you know, the last few decades. But in recent years, that decrease has sort of flattened out. And a big part of that reason is because of obesity and because of obesity and diabetes at an earlier age. So the longer you have risk factors like obesity and diabetes, the more time there is for plaque to build up in the coronary arteries and in other arteries in the body. So that's a really important factor. I think over time we've become quite good with treatments, say, of heart attack, for instance. Our systems have become quite good at getting patients needed treatments right away in a very timely manner to open up blocked arteries acutely. And so we saw some of the gains with that treatment. But I think what lags, or now what we're seeing in terms of patients living longer with heart disease, is we're seeing more congestive heart failure. So there are new therapies out there and developing therapies, medical therapy for congestive heart failure, including some medications that have been used more traditionally for diabetes that have been shown to be beneficial in congestive heart failure. And congestive heart failure is when the heart pumping function is impaired. There are advanced therapies can now offer support, hemodynamic support or blood pressure support for patients when they're getting procedures in terms of complex coronary interventions. So there are newer devices that we can use in terms of supporting patients, as well as getting them to maybe even semi-permanent or more permanent solutions like a heart pump, something called a left ventricular assist device, or even a heart transplant. There have been a number of innovations in structural heart disease, in particular in valve disease. The treatment of aortic valve disease has been revolutionized by the ability to deploy a new aortic valve through catheters rather than open heart surgery. The other thing is just to wrap this up is emerging therapies on obesity. I mean, I think lifestyle, exercise, diet, all of those things are really important. And the medications for obesity are showing promise in terms of beneficial cardiovascular effects. Obesity and exercise sort of affect all of those parameters. So blood pressure and cholesterol, like Dr. Lenore pointed out. So I really think that in the end, we need to start to be more innovative on how to make sure that all of these emerging therapies get out to all of our communities. And we need to be more innovative about, on a community level, how do we support people just living healthy lifestyles?
George, I think emerging therapists and being on top of emerging therapists is very important. But I also believe that because of socioeconomic inequities, that information often doesn't get to minority communities in terms of how to best take care of themselves. obesity was mentioned. One of the primary reasons for obesity, of course, is poor dietary choices. And I think not understanding the power of what we put in our mouths is one problem, and particularly poor communities, that leads to poor cardiovascular health. If we learn to increase the fiber intake, if we learn to eat more foods with a wider variety of color, if we learn if we understood the microbiome and the effect that the bacteria in the gut can have on all areas in our body. These are areas that I think we have been remiss in providing for the public in general, and for Black and Brown people in particular.
I also think I totally agree. I also think it's really important that we ensure that people have access to an easy access to healthy foods. When we think about what goes into a Happy Meal or fast food, and where fast food restaurants are located, where grocery stores are located, I mean, all of those are very important issues that we need to put front and center to make sure that all communities have the opportunity to eat healthy foods, to know what those healthy foods are. Even in, whether it's the workplace or at school or at church, really thinking about what types of foods are available to people, say for free or in vending machines. I think making a healthy choice, an easy choice, an accessible choice is important.
Right. So clearly, one strategy to lower the incidence of heart disease is to make sure that places where we live are not food ghettos, if you will. I'd like to get to something that Dr. Enix raised a few minutes ago, and that's racism. When I turned 50 a few years ago, a white cardiologist friend of mine said, "Do you have a cardiologist?" And I said, "No, I don't have a cardiologist. I'm in pretty good shape." He said, "Every Black man and Black woman age 50 and over should have a Black cardiologist." So Dr. Enix, why is that guy right?
I think racial and cultural concordance in the physician-patient relationship has been proven time and time again to be beneficial. There is the matter of trust. There is the matter of culture. And it has been demonstrated time and time again through research that patients will do better with a matching cultural concordance. And again, it has to do primarily with trust. And it's more than just an idea. There are hard facts. We know, for example, that there is a 50% increase in mortality in newborns when there is a lack of concordance. We know that there is an increased life when there is a concordance of cultural care. And so there is no question but that Black patients, if they can, will have a better chance of doing well with their cardiovascular disease if they identify a Black primary care physician, and a Black cardiologist. Now, of course, the problem with that goes back to the question of why there's a difference, access and socioeconomic status. The problem is the number of Black and brown physicians in many instances has declined. There are fewer Latino and Latinx physicians today than there were 30 years ago. There are fewer Black male physicians today than there were 30 years ago. Now, again, the reason for that are merely socioeconomical and historical. But unless those issues are addressed, it will become increasingly more difficult to identify a physician that'll bring about concordance.
It's no question that that this is a serious issue. And I know that's been top of mind, Dr. Lenore, for you and your practice, and also for the African American Wellness Project, right?
Right. You know, the concordance, I think, for those who don't know what that term means, is that if you have someone of your same culture who's reacting or taking care of you, and I think Dr. Enix is right on target. I would like to ask Dr. Enix a quick question, because he has operated on thousands of people. And I myself had an aortic valve issue, which in previous days would have required open heart surgery. And thanks to Dr. Enix and his intervention, I was able to get into a program at a university that was at the top of the line. And then that says, because I had that relationship. But I know you've operated on so many people, Dr. Enix. You've opened up the chest, you looked inside these arteries. And I wonder to you, what do you think when you see a young person or a person of middle age whose arteries are clogged because of lifestyle? What do you think to yourself as you look inside these vessels?
Well, it's clear to me, well, the answer is wrapped in something that, that Dr. McDonald and I made mention of earlier. Understanding how to take care of yourself. Interventions and medications and hospitalizations are all great and part of our culture. But understanding the ravages of hypertension and stress and not eating properly, I think this is the root of many of these differences that we see by the time the patients get to be 50 and 60 and on my operating table. And it's clear to me when I see some of the cholesterol plaque that is built up that Dr. McDonald most ably described earlier, that too often these patients have not taken the care of themselves that they might have. And by and large, that is because of a difference in the socioeconomic structure and poor access and not enough minority physicians to do away with the cultural discordance that you spoke about.
Well, I think we've learned an awful lot, not only about heart disease, but also about the meaning of the term concordance. This has been a great discussion. I want to thank all of our doctors, McDonald, Enix, and Lenore, and thank you for watching. We've got a lot more information on heart disease and a number of other issues as well on our website, aawellness.org. That's AA Wellness Project. I'm sorry, AA Wellness Watch. I'll get this right. aawellnesswatch.org. And Dr. Lenore, any final thoughts?
No, I just think that what was alluded to about today's Supreme Court decision, eliminating affirmative action in education, will spill over into heart disease. And if Justice Thomas wants to see what progress we have or have not made, I mean, look at the statistics on African-American health and health outcomes. Right now, they're right in front of it. And they have not changed statistically in comparison in the last 25 years. And so consequently, I'm looking for these kinds of decisions to spill over. And that drive for health equity, I think it's on a side road for a minute. But I do want the people to thank you, George, for putting this program together. Thank you, Dr. Enix, Dr. McDonald. And I want everyone who looked at it and listened to this program to go to aawellnessproject.org. That's aawellnessproject.org. You and I are going to have a little talk about that, George.
That's right, exactly right.
And please remember that health is your biggest asset, so protect it. This program is sponsored through an educational grant, AstraZeneca Pharmaceuticals.